And it's an extra special privilege for me to introduce Dr. Jinnah from Emory University, who is one of the world's experts in dystonia. And I had the privilege to work with him for the 12 years that I was at Emory University, and I gained so much knowledge and skills that I've been able to apply, hopefully, to patients that I see directly through my interactions and collaborations with Dr. Jinnah. I learned that you did your MD and PhD degrees out here at UCSD, so you've got some SoCal roots and knowledge here. And then was at Johns Hopkins. We missed each other for just by like 2 years. I left Hopkins for med school in 1992, and you got there in '94. And but at Emory is where he went after his time at Hopkins, and he's been on the faculty there, and is one of our most successful scientists, particularly in this realm. And so, really, we are truly privileged to have you here with us today and share your insights on the dystonias. So, without further ado, the stage is yours.
All right. Well, thank you, Michael, for that very generous introduction. I'm not sure I deserved it, but I do miss you. So someday you'll have to get back here so we can do something again together. It was great. It was great while you were here. Thanks to the group, Tony and the others of the group for inviting me. Happy to talk to you all here about what I know. I'm not an otolaryngologist, but I am a neurologist, and I deal with a lot of different types of dystonia, including laryngeal dystonia. I have had the great fortune of working with a lot of great otolaryngologists over the years on this condition. And what Mike asked me to talk about was how laryngeal dystonias may relate to other disorders. And I think you'll see why in just a moment. So let me figure out how to share the screen here. I'm going to turn this on. Okay, great. So I think there are a couple of terms that we often use interchangeably, and they are spasmodic dysphonia and laryngeal dystonia. They're roughly similar. I think laryngeal dystonia is a group of disorders, and spasmodic dysphonia is one of them. And what I want to tell you briefly about is the relationship among these things, and then their relationship to other types of dystonia, and why you might be interested to know that. I like to keep things kind of informal, so I'm not gonna lecture to you for a whole hour. Just gonna talk for about 15 minutes and then open it up to questions. So as I go, think about what things you might want to know further or other questions, and you can either put them in the chat or send them to Tony or Kim or Mike, and then they can review them once I'm through this just short 15 slides here. All right. So the laryngeal dystonias are part of a larger family of disorders. And within the laryngeal dystonia group, we have spasmodic dysphonia. Many of you probably already know their subtypes of that. We call them adductor or abductor, depending on which muscles and how your voice sounds. Mixed spasmodic dysphonia is also common. Then some patients only develop laryngeal dystonia when they sing. And then occasionally patients develop laryngeal dystonia with breathing and not necessarily talking. But these are all subtypes of laryngeal dystonia that you may have heard about already. But in fact, the laryngeal dystonias are part of a much bigger family of conditions, and they are called the dystonias. And these disorders are defined by overcontraction of certain muscles, leading to abnormal movements and postures. And I'm going to show you some of the examples of that, and then I'm going to tell you why you might want to know about these things. So I am going to move to the next slide, I think. Let's see. Doesn't want to go. There we go. All right. I think my computer is a little slow tonight. Probably the most common of the other dystonias, the larger families of dystonias, is what we call cervical dystonia, which involves the neck. And you can see some pictures over here of what it looks like. Sometimes there's turning of the head to one side. Sometimes there's tilting of the head. Sometimes there's bending forward or bending backward. Usually there's some combination of these problems. And here's some renditions of some of the patients we've seen over the years. You can see various combinations of turning and tilting here, and here's turning and tilting down. Here's mostly tilting to one direction or another, bending forward or backward. And so this is a condition that is considered one of the family members of the dystonias that's related to the laryngeal dystonias. And I'll come back to why that's relevant in a moment. Probably the next most common one is what we call dystonia of the face. Here are some pictures again over here. This is a person who has dystonia, excessive muscle contraction of the eye region of the upper face. We call this blepharospasm. Here in C and D, you have pictures of individuals who have involvement of the lower part of the face, mouth region. We call that oromandibular dystonia. And then there are some who have both upper face and lower face, and occasionally even tongue, and we call that lingual dystonia. So that's another group of disorders characterized by excessive muscle contractions leading to abnormal movements and postures. Let's see here. For some reason, I'm getting a beeping signal. There we go. All right. Dystonia can also affect a limb, for example, an arm or leg, a hand or foot. And here in this picture, you see some characteristic hand postures. Sometimes you get this fisting posture. Other times you get this funny posture of the fingers. It's been called swan neck deformity because somebody thought this looked like a swan's neck. Here you can see someone with the abnormalities of their hands. This is called spooning of the hands down here. These are all different types of dystonia of the hands. And here you can have an example of a foot. Here's a person with one foot that's turned in. Here's a person with a foot where the big toe wants to stick up all the time. And so these are examples of excessive muscle contraction leading to abnormal postures and movements of the limbs. So why are these conditions all grouped together? I mean, they kind of look totally different, right? They don't really resemble each other if you look at them superficially at all. So why are they put together? Well, there's a couple of reasons which are shown in this slide. And one of the reasons is that one type sometimes spreads into another type. So you might start with one type and then you might develop the second type. And I'll show you a little bit what that means in a moment. And this is important for prognosis and treatment because sometimes when patients begin to develop that second problem, they think, uh-oh, now I have a whole new disorder. But in fact, it's not a new disorder. It's the same thing. It's just spreading from one area of the body to the other. Fortunately, it doesn't happen very often. You don't have to worry too much about it. But when it does, you know what it is, and you don't really have to worry because it's not a new problem. Another reason that these disorders are grouped together is because they share some common causes, and I'll show you some example of genetic causes that might cause one or the other dystonia. They also share some coexisting problems, most notably tremor. Patients with all different kinds of dystonia often also have tremor. It's not a separate disorder. It's so common that we consider it part of the same syndrome. And then finally, the treatments are actually often somewhat similar across the group. We treat most of them with botulinum toxin injections, but there are also some oral medications and occasionally some surgeries that are done as well. So here's a little bit of a complicated slide. So let me walk you through this. This is a slide that shows how one type can spread into another. And what you're looking at down here at the bottom on this, what we call the x-axis is years. So this is a study that was done for 10 years. They followed people for 10 years. And over on this axis, you can see basically the proportion of people who stayed only with dystonia in the starting place. And this blue line shows you that it drops down, and that blue line is actually the eye region. So if you start with your dystonia in the eye region with blepharospasm, then you're much more likely to develop another type of dystonia over the years. And you can see here at 5 years, about half the patients with blepharospasm will have spread into dystonia in some other region. Now, up at the top here in the green, what we have is the neck. So if you start with dystonia in your neck region, only about 10, maybe 20% of people will spread to have dystonia in a different region. And the laryngeal dystonia is in the middle here with hand, and that is over a period of about 5 or 10 years, maybe 20% of people will spread to have dystonia in another region. When it spreads, it tends to spread to the nearby region. So if you start out with laryngeal dystonia, it might, for example, creep into the neck region or into the lower mouth region, sometimes into the shoulder, that kind of thing, occasionally into the hand. So that's what we know about what happens with one type spreading to have another. And that's a good bit of evidence that these are somehow related to each other because people develop one and then the other. Here's another reason why we think these conditions should be all grouped together as a family, and that is sometimes we'll see family members that have the same disorder. So here's an example of a family where there's 1, 2, 3, 4, 5 people. 2 of them have laryngeal dystonia and the rest are healthy. But on occasion, we'll see families like this instead. That is, one of them will have laryngeal dystonia and another will have cervical dystonia. And that argues to us that there's some genetic contribution in this family that causes one or the other disorder. And that's another piece of evidence that suggests they may be related. And occasionally, we'll see families like this. One person has laryngeal dystonia, one patient has facial dystonia, another person has something in their hand, and another person has something in their neck. Now, it turns out that these kinds of families are not really very common, but the fact that they occur tells us that these conditions are probably related and probably related to some particular gene that they all share. Now, by now, it turns out we know a bunch of these genes already, and they are shown here. Some of the more common genes that can cause a variety of different kinds of dystonia are shown here. I'm not going to go through these in details. They just have basically letters and numbers, and that's how they're named. But these are the kinds of genes that can sometimes cause multiple different kinds of dystonia in the same family. Okay. Now, another reason that we group the dystonias together in a family is they often share other related problems, and one of them is tremor. So many of you probably know that lots of people with laryngeal dystonia also have tremor. And this is actually a table which shows a bunch of studies going back all the way to 2003 to most recent from various parts of the world. And the numbers of cases with laryngeal dystonia that they studied are here. And you can see the percentage of those cases who also had a tremor. And a tremor is kind of a shaking movement. It's kind of a shaking movement like this. It can commonly affect the hands, but it can affect your voice. It can affect your hand, your foot. It can affect pretty much anything. And it turns out that tremor is very common in laryngeal dystonia, but it's also common in most of the other dystonias as well. This is important because a lot of times patients will develop one of these disorders, tremor or laryngeal dystonia, and then over the years they develop the other one and they're worried that they're developing some new problem, but they're not. This is just part of the condition because it's so common, we see it so frequently. All right. In other types of dystonia, for example, cervical dystonia or blepharospasm or hand dystonia, 20 to 75% of them also have a tremor, as I mentioned earlier. And it's important because sometimes one starts before the other. Sometimes the dystonia comes first. Sometimes the tremor comes first. Occasionally they both come at the same time, but usually one comes first. And then after a few months, or sometimes after a few years or even 10 years, the other one comes. And that's why we think they're probably related to each other because they're so commonly seen together. And it turns out that there are some families out there where one person has dystonia and another person has a tremor. So again, some evidence that some gene may be responsible for this problem, or both of these problems occurring together like this. All right, so here is the list of reasons why we consider these disorders and group them all together. One type sometimes spreads to another, and this is important for a prognosis, which means predicting the future. It's also important for treatment because they tend to be treated in the same way. The other reason we group these conditions together is because they share some common causes. I shared with you some genetic examples, but in fact, there are a couple medications out there that we know can cause dystonia, and they cause various different types of dystonia. For example, laryngeal dystonia or cervical dystonia. So it's not only genetics that can cause both problems. All of the dystonias share coexisting problems, most notably tremor, some other things as well, but that's probably the biggest one. And then finally, the treatments tend to be similar across these groups, botulinum toxins and oral medications. Now, one of the reasons this is important to people like me who do research is because when we learn something from one subtype of dystonia, what that means is we can think about applying what we've learned to another subtype of dystonia. And that's what we've been doing over the years. For example, finding genes in one subtype, and then we look in another, finding a treatment that works in one subtype, and then look in another. And that's why thinking about these conditions together as a group is helpful, because I think there's strength in numbers, and the laryngeal dystonias are not all alone, only isolated conditions studied by themselves. So I mentioned already the implications for management, just very, very briefly. Probably one of the biggest implications relates to counseling. That is when one patient develops multiple problems over the years. It's not the case that they're developing multiple different problems. It's all part of the same syndrome. So it's not like you have to worry that you have so many different problems. It's just that they are all somehow being caused by the same thing. Tremor is a good example of this. We often see this situation here where one person has a certain type of dystonia, and then what happens is something strange happens in a family member and nobody knows what's going on. But in fact, if you know that this might be a related condition, it helps you get to the diagnosis of that person in the family much quicker than if you would otherwise just have them in isolation. And then finally, we talked a little bit about implications for treatment. Spread in particular requires what I call multidisciplinary treatment. That means sometimes multiple doctors. So most patients with laryngeal dystonia are treated by otolaryngologists, like Dr. Johns. And most patients with cervical dystonia in the neck, they're treated by neurologists like me. And then sometimes patients with blepharospasm, that is around the eye region, they're treated by ophthalmology doctors. And so when you have multiple problems, you have to somehow coordinate the care among the different doctors so they can all get their treatment. All of those things can be treated on the same day. And then finally, tremor, if it becomes a problem, can be treated with some oral medications in addition to botulinum toxin if it becomes a big problem, particularly in the hands or other regions of the body. So I believe that may be my last slide. So I'm going to unshare here if I can figure out how to do that. And then just open things up, I think, to questions in case there are any.
I know non-invasive focal ultrasound focused on the brain is being used currently for treatment of hand tremor. Why is it that the part of the brain that causes that has been identified, but in regard to voice problems, specifically SD, it is so much more difficult?
Yeah, that is a very good question. So, Tony, you're right. Focus ultrasound has been developed over the past 10 years or so and seems to be a very good treatment for hand tremors. But it turns out when you apply it to other types of tremors, for example, tremor of the head and neck or tremor of the voice, the results are not so reliable. And the reasons for that are not entirely known, but the suspicion is that tremor comes from a certain brain region, but that brain region is actually kind of big. So if you focus your ultrasound on one part of that region, it might be good for hand tremor, but not voice tremor. So it's possible we just haven't found the region that is useful for voice tremor. Now, the other problem with voice tremor in particular with focused ultrasound is one of the big side effects of focused ultrasound is what we call dysphagia, trouble swallowing. And if you already have trouble with your voice, many doctors are a little bit nervous that making a second problem in the laryngeal region relating to swallowing and voice might be a little bit risky. So I have seen focused ultrasound being applied to hand tremors a lot. I have seen it being applied to head tremors a little bit, but not so much. I have not seen doctors being enthusiastic about applying it to voice tremor because of its unpredictable effects and the risk of a side effect that could make things worse. And so I think those are the main regions why it hasn't gotten there, but it will. Like I said before, what we learn from one disorder, we can often apply to another. And I think it's just a matter of time before people refine the technique, figure out the voice tremor region of the brain that really needs to be targeted, and begin to apply it more safely.
Thank you.
Good question. Yeah.
My second question is in regard to the genes that have been discovered that cause a specific dystonia, are there any interventions that can be made prior to the dystonia exhibiting itself?
Yeah, that's a good question. At the moment, I would say among the 200 or so genes we know, only a handful of them, maybe 5, have really good treatments. And those treatments can be applied as soon as the problem emerges, but they are not the kinds of treatments that are applied to prevent it from emerging. And I think that's what you're getting at, and that would be a great thing that we could have if we could develop it. The field of genetics and dystonia is relatively new. I would say it's just less than 10 years old when we started finding real genes for dystonia. 10 years seems like a long time, but in fact, it's pretty new in terms of the research progress. I think we'll get there. I don't think we have it yet. But with the number of genes being found and the interest now in the pharmaceutical companies for targeting those things, we'll get something probably within the next few years, I guess.
Do you find that the linkage is transmitted through the maternal or paternal side? And is there any cultural makeup like Ashkenazi Jews?
Yeah, that's another good question. I think most of the genes we know can be transmitted by either mom or dad. There's only a handful of genes that can be transmitted by only dad or only mom, but they're even rarer. I think certain ethnic populations have a higher risk for some of these genes, but as far as I know, for spasmodic dysphonia in particular, there aren't any particular genes or ethnic risks that we know of. Now, at some point we may learn about them, but at the moment, I don't think we have any specifically for laryngeal dystonia.
Thank you. anyone else?
We do have another question in the chat. Are there any other treatment options besides Botox for spasmodic dysphonia?
Yeah, that's a good question. I would say that Botox tends to be the most frequently used because it works the best. But there are other options out there. Some people do use oral medications like benzodiazepines. The problem is they don't work all that great and they have a lot of side effects. So that's why we prefer Botox. There are several surgeries that are out there as well for spasmodic dysphonia. I would say they're not widely available throughout the US, and there remains some uncertainty about which one is the best or whether they're better than Botox. So I think there's still a lot to learn about alternative treatments.
I have a follow-up question about that. There are medications that work well for tardive dyskinesia, like Ingrezza or Austedo. Has anyone looked at the use of those for SD?
Yeah, good question. And the answer is yes. There's a number of medications out there that are used to treat related conditions like tardive syndromes, which sometimes can present as laryngeal dystonia, or Parkinson's syndromes, which sometimes have a voice disorder that resembles laryngeal dystonia. I would say that things like Ingrezza and tardive dyskinesia medicines haven't really proved to be particularly effective for the dystonias at the moment, so we don't tend to use them. But there are actually at the moment several drug companies working on things that they believe at the moment are good for any type of dystonia. And so when those become available, I think then we would have something with a little bit broader usefulness.
And actually, first, I want to introduce Eugenia Castro, who's on the call as well, who's one of our outstanding speech language pathologists, specifically because there's a question about voice therapy that's in here. And I'd also like to introduce, if he's available, Dr. Carter Wright, who is one of our outstanding laryngologists at Wake Forest University, and we work together a lot. And he tuned in here from across the country. Thanks. And so we have some other potential question answerers here. But there is a question about speech therapy and its effectiveness for SD. Do you want to field that, Eugenia?
Yes, thank you so much, Dr. Johns, for the introduction. I was actually just typing an answer to that question at the same time. But yeah, so as of right now, voice therapy is not the gold standard treatment. So we use Botox as the gold standard treatment. However, for some people, voice therapy is effective at dealing with the concomitant behaviors that happen. So as a concomitant treatment to deal with muscle tension that happens from fighting those voice breaks. It's so often every day in your life. So in voice therapy, I would say it's usually no more than 4 sessions, sometimes even less. Some people need a little bit more guidance, 4 to 6 sessions sometimes. But no more than that, because the treatment, the gold standard baseline treatment, will be the Botox injections as of right now. That being said, we can treat, again, those extra tension or discomfort, and we can find a compensatory way of using the voice in a way that doesn't produce so much symptoms or so many symptoms. And one other thing that we can do in voice therapy is sometimes extend a little bit the period between one injection and the other. So kind of like extending the benefits by you having a different power over your voice, of understanding of how you use it, and finding a more optimal or economic way to talk and to use your voice without having to fight those breaks so hard. But yet again, voice therapy is not something that is going to effectively cure spasmodic dysphonia, but we can definitely help. Definitely helpful for a lot of people.
And as a follow-up to that, while we're on the same topic, Laura asked a question about sort of specific strategies that are used in speech and voice therapy, and maybe a good time to share kind of how we just can't have like a take-home sheet of like, exercises that you do.
Yes, absolutely. So we base in voice therapy as a general rule, we have the kind of like too much tension, too much effort kind of group of exercises and techniques, and the too little, right? So those people who have too weak voice that is too weak. So for those people, we use kind of like an exercise training, like getting your voice to the gym, right? And I'm not overgeneralizing voice therapy here. It's years of study, but I'm just doing a summary. For spasmodic dysphonia, we want to deal with the other group. We call it exercises, but it's not technically exercises. They are techniques to find your voice in a more pliable, soft, amenable way that doesn't require so much tension. For people who specifically have pain or tightness in the neck surrounding in the paralaryngeal muscles, we might add on digital manipulation of the larynx or myofascial release of the head and neck techniques, meaning some type of massage to the larynx to dissolve the tension that appears. For other people, we might use techniques that are called kind of like flow phonation, which is kind of embracing the breathiness in your voice after your injection and following with a very soft voice. I don't know if you perceive the difference in my voice when I just did that. Kind of like a very soft, in contrast with a very pressed voice that can potentially happen from, and I'm a very bad imitator, but like it's a broad way to explain. We're trying to move away from the tension and into softness and flow of air with voice together. We might also implement things that are very popular to reduce this tension, like strophonation, lip trills, like which are all within the family of SOVT. If you're a curious soul, there's a lot out there in the internet and the research community on that technique, which stands for semi-occluded vocal tract exercises.
SOVT.
SOVT, yes. And those are a big group of exercises that we might potentially implement. And techniques also like resonant voice, where we find resonance versus, the feeling that you might have when you have SD, as that your voice is always in your throat, kind of trapped in there. We might find resonant voice to find more things in the mouth, like like humming, might involve some humming, or where the tongue is touching the palate. So articulators and resonators, and we might discover that those are your friends, and you can use it as a kind of like an anchor or hook or a reset button as you're talking. Finding those resonance in the front of the face again, if you're gone too much into your throat with tightness. Once again, this is a very fast and short summary of the realm of technique that we have in voice therapy, but I wanted to do a thorough answer. I hope that was what you were looking for, Laura. If not, let me know. Says thank you for sharing some big strategies. Okay,
Thanks,
great.
Eugenia.
Of course.
And Joanne had a question,
Yes.
another good one. How and that I'll field. How do you differentiate essential vocal tremor from spasmodic? It says dysphagia, but I think you mean spasmodic dysphonia. And we do it in two ways: by listening and by looking. For the listening part, there are characteristic features that we can detect in the voice based on the characteristics of the condition. So the dystonias, abnormal, irregular contractions that versus tremor, abnormal, very regular contractions. And as it turns out, people with laryngeal dystonia or spasmodic dysphonia, sustained phonation, so ah or e, tends to come out pretty smoothly. But in connected speech, we mow our lawn all year. The breaks come. Now, tremor, people can hide the tremor in free-running speech because the sound is changing so much, but in sustained phonation, it comes out. So by listening. And the second is by looking. And so otolaryngologists love their scopes, as you know, and I try to apply it as infrequently as possible for our laryngeal dystonia patients because it's actually not fun. But it's not terrible in the end of the day. And our goal with looking, remember, with these conditions, the problem isn't in the larynx. The problem's in the brain. We're going to get to Alex's question then next when we'll pass the ball back to Dr. Jinnah. The larynx is normal, and so we're expecting to see a normal larynx. And so why do it? Well, we can see tremor. So we can't see the breaks of the dystonias when we look on laryngoscopy very well. Unlike for the eyes with blepharospasm where you can see that. The movements are so tiny and small, it's really hard to see. But the tremor we can see. The tremor, the whole throat wall starts to shake on the scope, and so we can see it. So those are the two ways that we differentiate it. And it's important to differentiate because the treatment is typically better for Botox with the dystonias because only a focal set of muscles is typically involved. With vocal tremor, it's not just, say, the vocal cord adductors, bring them together, or abductors that's involved. There is commonly what we call the whole vocal tract, the whole throat, is involved in shaking. And so we can't deliver Botox, weaken those muscles because you lose a little ability to swallow and even form speech. And so that creates a challenge with voice, for vocal tremor. Some of the medications for tremor do help for laryngeal tremor, and this is a great study that I'm proud of that I did with Dr. Jinnah back in the day. They did a little case control study that there is some benefit to these medications. But kicking it back to Dr. Jinnah, Alex says since it's a neurological disorder, larynx is normal. Maybe just a brief smorgasbord of the treatments that kind of are trying to target the root source.
Yeah, great discussion, Mike. There are a couple things that I think target the neurological part of it and help a little bit. One are the oral medications. So those medications actually target the brain pathways that are responsible in part for tremor or laryngeal dystonia. So those oral medications are working on your brain. Deep brain stimulation and focused ultrasound are the same, although they haven't really been refined very well specifically for the voice region. I think one of the most interesting things is the medicines we have for tremor that Mike talked to you about just a moment ago, they do work reasonably well for people who have vocal tremor, but they are not perfect. They've got some side effects, so they're not necessarily favorites of everyone. At the moment, in the past year, the neurology community has been doing 4 different trials for new medicines for tremor. And they're focusing on hand tremor first. But my guess is that if one of those 4 drugs becomes a new tremor treatment for hands, that we'll all begin to try it for people who have tremor in other regions like the voice. And so that's really promising, I think. Probably within the next year or so, I think we might have some new candidates out there for oral medicines.
That is exciting.
Yeah.
Yes.
Dr. Jinnah, what any thoughts or experience on Daxify? And just as a little backdrop for the group, Daxify is a newly synthesized botulinum toxin that has been purported to give longer lasting effects. And it is available now, but not widely available. And nobody has a lot of experience with it. But Dr. Jinnah, I'm curious what you know.
Yeah, so this is a new version of botulinum toxin, similar to Botox, except that it was designed with the hope that it would last longer. And I actually have tried it. And I would say it does indeed probably last longer for some patients, not everyone. Might not last as long as the advertisements say. I don't think it will go for 6 or 8 months. But when I use it, I'm using it for the neck. And of course, the larynx and the muscles of the larynx are much smaller and more sensitive. So it is very feasible that a tiny dose of Daxxify could last a lot longer there. And I think it's just a matter of someone getting it and trying it. And the good news is that after this company came along and said, hey, we can make a better Botox because we can make it last longer, there's now a second company that has recently launched also a long-acting version of botulinum toxin, and that's actually being tested now.
Ooh, what's that? What is that? Does it have a name yet?
It does not have a name. It's called IPN, some numbers.
Numbers. Got it.
They'll give it a fancy name when it comes out, but it's almost certain that it will work because it's a modification of an existing molecule that already works. It's just that they made it so it lasts longer.
When you've used Daxxify for cervical dystonia, have you noticed the side effect? Is there a side effect period of like increased weakness that is greater with Botox, or is that the same? And the reason why I ask is the biggest issue we have with laryngeal Botox, as you know, is that side effect period. And so we can get a longer clinical effect by paying the price with increased side effect up front. And I was wondering with Daxi, would it just lead to a really long side effect up front, which might not be, favorable treatment profile?
Yeah, Mike, I think that's exactly the issue that everyone's concerned about. I don't think there's enough experience yet out there with using it repeatedly in patients, but a longer acting therapeutic action carries, of course, the likely risk that there's a longer acting side effect profile. So I think the idea behind Daxxify is that instead of having a molecule that sort of gets you better and then you wear off and then you get better and you wear off, is that if you can give smaller doses, smaller, safer doses, you're going to have that swing a little bit less. And I think in terms of the voice, I've heard lots of people who've had side effects from that. I think it's fairly common. I think there is a risk that side effect could be longer, but I think that might need to be addressed by using a smaller dose and catching patients before they wear off. And if you can do that, I think it might give a smoother and more stable benefit to the effect. But we don't know yet. We're hoping that's what will happen.
Yeah, and therein lies the art of the treatment, which remains.
And Dr. Johns, I just wanted to add that Dr. Clark Rosen at UCSF is actually doing a small clinical trial on Daxxify and SD. So I believe he's almost wrapping that one up. I think he enrolled 10 people. And so it was an investigator-initiated study, and our organization helped support that. So we're really excited to see what the results were and get some data on that so that can be shared with the laryngologist.
We're waiting for the preliminary report with bated breath. I have spoken with Dr. Rosen and have gotten a little snapshot, and his sense, and it's small, it's a very small study, is that the side effects aren't worse, but not everybody lasts longer. But there is a cohort, maybe of a third, that seems to be lasting a good bit longer, and it sounds like maybe there was some that could be a little bit shorter. But again, the dose titration and art is something that we do serially over time by a little bit of trial and error. So I've based on just my verbal communication, I'm enthusiastic about at least trying it. The challenge is, my understanding is it's not really insurance covered at this point in time. But Dr. Jinnah, you may know better than me, but my understanding is not that. But my thought is I'm going to try to see if we can't get it in our clinics at USC, and for people who are willing to try, who want to try, we could offer it, and hopefully at a reasonable price point if insurance doesn't cover it. But unfortunately, they've taken all those levers out of the hands of the physicians.
Yeah, I agree, Mike. It's FDA approved for cervical dystonia, so I think insurers will cover that. Whether they cover other indications is a matter of time to see if they if you know if they'll cover it. One of the benefits, I think, beyond just its long effect, is that it's actually cheaper. So they rolled it out a little bit less expensive than Botox because they know they have to compete with Botox. So if insurers see that, they may be more willing to cover it instead of Botox or along with Botox. So I think there's definitely hope there. And my experience was similar to what you just described. I had a handful of patients for whom the Daxxify did indeed seem to last a lot longer. And then I had others who felt like it was no different than Botox. So I think people are different, and we just have to try it and learn.
We have another question from Tony regarding the essential tremor and dystonia of the hand. And if I didn't get this right, Tony, correct me. It says is essential tremor the same as hand dystonia? I think we're talking about hand tremor and hand dystonia.
Yes.
Yeah. So you can have dystonia of your hand, you could have tremor of your hand, or you can have both combined, just like the voice. And it's not so uncommon to have both. I would say about maybe a third to half the people with hand dystonia also have a tremor. And like we heard earlier, it's sometimes a little bit hard to separate them, but we do it by looking mainly. We can see the hand, of course, and it looks a little bit different to an expert eye, a dystonia versus tremor.
Thank you.
And another question in that line, why doesn't Botox have a positive effect on some people? And I think maybe for a little context, we do have situations in the larynx with the complexity of, vocal fold adduction and abduction. And when there's abnormalities of both or concomitant regional dystonias in our area, we do have some folks who we just can't seem to get benefit with Botox or any significant symptom improvement. Do you find, is that the same in the cervical dystonias or the hand, or is it really a consequence of kind of laryngeal function and how it works versus the hand and how it works?
Yeah, I would say it depends on the type of dystonia. So for cervical dystonia, the neck, I would say probably 95% of people can get a good benefit. Not everyone. Why those 5% don't get a good benefit is a little complicated. They have a particularly complex disorder, or they're resistant to it, or some other reason. In blepharospasm, I would say the success rate is closer to 80-85%. When it comes to hand, it's probably about 50%.
Oh.
And the reason for that is in your hand, there's, dozens of muscles from here to here. And one muscle controls each joint of your finger going up or down. So actually selecting the muscles with the right doses is really, really tough. And I think it's probably more similar to the larynx, where the muscles are small, they're sensitive, they're close together. And getting exactly the right combination is sometimes tough.
Yeah.
But it varies.
Super insightful. Maybe a couple more questions, Dr. Jinnah. I know it's 9 o'clock your time, and for me, that is definitely in the bedtime red zone. I understand. Megan asked. Oh yeah.
If you don't
Laura.
mind.
Yeah.
I am actually joining the call from Atlanta, which I believe is where Dr. Jinnah is located. And I am actually a participant in the dystonia study that his department is conducting. At the beginning, my initial meeting for that study, they took a blood sample. And I said, why are you taking a blood sample when I have a problem with my voice? And they said they're checking for biomarkers. So Dr. Jinnah, could you explain more about what that means and what the initial findings are?
Yeah, a biomarker is a blood test that can be used to detect the disorder. So for example, in diabetes, the biomarker is your blood sugar, right? If your blood sugar is too high, then you have a biomarker that says there's something wrong with your control of sugar. And so we measure blood glucose as a biomarker for diabetes and its severity. There's been a lot of interest in neurology to develop similar biomarkers for neurological diseases, and we thought we would try to do that for the dystonias. So we collected a lot of blood samples, and we began to look for things in the blood that might be causing or at least associated with the various types of dystonia that we were studying, including laryngeal dystonia. Actually, a study was just published last year. We had about 200 people who gave us blood samples, and we just targeted every protein in the blood we could find. And it turns out we could measure about 6,000 proteins. And of those 6,000, 15 of them were expressed at levels that were not normal. And now we have to figure out why. And we have to figure out if those proteins can serve as a biomarker. So thank you for donating your samples. This helps us find these kinds of things. And if we can find this type of thing, it's good for two things. Number one, there are people out in the community, out in the US and other parts of the world who don't have access to people like Mike Johns and speech language pathologists who can really diagnose this problem really quickly. And so having a biomarker would be a first clue for them that they need to have a specialist look at their voice or their problem. So it helps in diagnosis. But when we know what these proteins are, it helps us a little bit understand maybe where they're coming from and why they would be abnormal. Helps us find the pathway that could be biologically responsible for the condition. So that's why there's so much enthusiasm for doing this. Hope that makes sense. It's kind of a complicated answer, but I was toying with the idea of putting that biomarker slide in here, and then I thought, oh, no, that graph is too ugly. Nobody's going to want to see that.
And then maybe lastly for you, Dr. Jinnah, I'm happy to stay on to talk about a couple questions that have popped up specific to laryngeal dystonia. Gene editing, CRISPR technology, sickle cell. We're seeing these stories come of cures with this. Anything on the horizons there?
Yeah, there's a lot of enthusiasm for gene editing and fixing genetic diseases, at least for most forms of dystonia, including laryngeal dystonia. Most people don't have a gene that we know we need to fix. And so right there, I think that technology might not be as good for us as it is for other disorders like sickle cell that you mentioned. Then the second problem with the gene editing is that if the dystonias, including laryngeal dystonias, are neurological diseases that come from some signaling pathway in the brain, it means you would have to gene edit in your brain. And at the moment, we don't really have an easy way to do that. Probably it will come in the future, but right now, I think most people are focusing on easy to access tissues like the blood or liver. But getting a gene editing technology that works in brain has yet so far not been easy to find.
Dr. Jinnah, it's been a delight having you with us here for the past hour. You are always so clear and articulate and can make these complex concepts very graspable. And I very much appreciate it. And I hope our paths cross soon.
Great. Well, it's good to see you again. And hopefully our paths will cross.
Echo what Dr. John said. Thank you very much.
All right. Well, thank you, everyone.
Have a good day. Get some sleep.
All right. You too.
So anyone who wants to stay on and chat about SD with me or Dr. Johns is welcome to. We'll stay a few minutes.
We got one question from Alex. It says, is it possible for the muscles associated with ADAB SD to recover over time naturally without any Botox treatment or surgery? So it's a good question. And sometimes we will see people who have classic sounding features of dystonia and it gets completely better or partially better. And what we think is going on there, because we know that the dystonias in general do not sort of self-cure, what we believe is happening there is that either the primary condition was more of muscle tension and vocal posture that sounded and sometimes looks like spasmodic dysphonia, or there's spasmodic dysphonia and then a significant amount of muscle tension on top of that, which is also really common. And as some of that muscle tension is worked out, then the symptoms are just less. And so even though the condition persists. So hopefully that answers that one.